Good morning to all. Today we'll be talking about mechanical circulatory support in cardiogenic shock. I am Dr. Karthik, Associate Professor of Cardiology, UNMICRC Hospital. So we've learned that the traditional definition of cardiogenic shock from the various trials of cardiogenic shock show persistent systolic blood pressure which is less than 90 millimeters of mercury, not responsive to fluid administration alone. This is secondary to cardiac dysfunction and is associated with signs of hypoperfusion of a cardiac index less than 2.2 liter per minute per meter square and a pulmonary capillary wedge pressure which is more than 15 millimeters of mercury. The European Journal of Heart Failure in 2020, they define cardiogenic shock as a syndrome caused by a primary cardiovascular disorder in which inadequate cardiac output results in a life-threatening state of tissue hypoperfusion associated with impairment of tissue oxygen metabolism and hyperlactatemia, which depending on its severity may result in multi-organ dysfunction and death. So, cardiogenic shock is a clinical diagnosis. Although recent ESC guidelines and trials, including the SHOCK trial, the IBP SHOCK trial, they include hypotension, defined as systolic blood pressure less than 90 millimeters of mercury for more than 30 minutes, or the need for catecholamines to maintain a blood pressure more than 90 millimeters of mercury. Sometimes you may have compensatory vasoconstriction, which may preserve BP, while the tissue perfusion and oxygenation may be significantly decreased. And thus, this is the concept of normotensive shock, which means that hypotension is usually associated with cardiogenic shock, but is not a prerequisite to diagnose cardiogenic shock. So hypoperfusion is not always accompanied by hypotension, and hypotension without hypoperfusion may portend a better prognosis. Now this is the most important recent update in cardiogenic shock. In 2020, a group of people, they sat down and defined a SCAI stages of cardiogenic shock, right from A, B, C, D to E. That is right from the lowest category, which is the at-risk patient, then beginning of cardiogenic shock, classic cardiogenic shock, deteriorating and extremis. Now we'll go into the detail of what is the parameters which are assessed in this SCAI stages. So there are three things which are looked at in any stage of cardiogenic shock. One is the physical examination, the other is the biochemical markers, and the third is the hemodynamics. So what is stage A? So a stage A patient is a patient who has no signs or symptoms of cardiogenic shock, but is at risk for its development. So these patients may include those with an NSTEMI less commonly, or in fact more commonly in some cases, STEMI, especially a large anterior myocardial infarction or a very large dominant RCA infarction, acute or chronic cardiac failure. So when you examine these patients, the patients may typically have a normal JVP, clear lungs, warm and well perfused with strong distal pulses and with normal mentation. The biochemical markers may be essentially normal, that is the lactates would be normal, the renal function and the LFTs would be normal. The hemodynamic assessment, if done, then it would show a blood pressure which is more than 100 millimeters of mercury or normal for that patient. And if you put in an invasive catheter or a PA catheter and you get the cardiac index or cardiac output, you find that the cardiac index is more than 2.5 liter per minute per meter square with a central venous pressure which is less than 10 and a PA saturation more than or equal to 65. Then you come to the stage B. So here the patient would have hypotension or tachycardia or both, but there would not be hypoperfusion. So on physical examination, the patient would have an elevated JVP. There will be rales in the lung fields. The patient is well perfused and warm with strong distal pulses and normal mentation. The lactates would be normal and the renal function would also be normal, but the patient may show an elevated BNP or NT-proBNP. The patient may have a systolic blood pressure which is less than 90 or a mean arterial pressure which is less than 60, or there is a fall in the blood pressure more than 30 millimeters from the baseline with the tachycardia or a pulse which is more than 100 beats per minute. And if hemodynamics are done, the patient would have a cardiac index which is more than 2.2 and the PA sats would still be more than 65. Then we come to the classic cardiogenic shock. So this is the classic or hallmark of any cardiogenic shock is hypoperfusion. And this is the stage through which all the patients would go. So from a stage C, the patient would go either to a stage B or A depending upon the success of the intervention or the response or strength of the mechanical circulatory support, or the patient may go from stage C to stage D or E. So these are the patients who require interventions such as inotropes or pressors or a percutaneous MCS with revascularization in case of ACS shock to restore perfusion. So these patients may look unwell, they may be panicky, they may be ashen, mottled, dusky, and they may show signs of volume overload. There may be rales in the chest, more than 50% of the lung fields, and the patient may be cold, clammy, with a urine output which is less than 30 ml per hour, and there will be deterioration in the mental status. If you look at the biochemical parameters, the lactate would be more than 2 millimole per liter, the creatinine would double, or there's a more than 30% or 50% loss of the GFR with an increasing LFTs and BNP. And if you put in an invasive catheter, you will find that the cardiac index is less than 2.2 along with hypotension or a fall in the mean arterial pressure, with a pulmonary capillary wedge pressure which is more than 15, with a right atrial pressure to central venous pressure ratio of more than 0.8, a PAPI, which we'll come to later, which is less than 1.85, or a CPO, which is cardiac power output, which is less than or equal to or less than 0.6. Then this is the state of deteriorating cardiogenic shock. It is similar to stage C, but all the parameters would be worse. The patient may require more than one inotrope or would require an upscaling or escalation of the mechanical circulatory support. And this stage would be diagnosed only if you have at least 30 minutes of observation. That is, you've started the patient on some mechanical circulatory support or inotrope, and then you wait and you still feel that the lactates and the blood parameters, the biochemical parameters and the physical parameters are worsening, as well as worsening hemodynamics. And this is the highly unstable stage, the stage E, where the patient is highly unstable, cardiovascular collapse can occur, and any patient who comes with an out of hospital cardiac arrest would be placed in stage E, and these patients would require support with multiple simultaneous acute interventions, including an ECMO facilitated eCPR. Now, this is the pathophysiology of any cardiogenic shock, whether it be HF shock or acute MI shock. So you have systolic and diastolic dysfunction. There is a decrease in the cardiac output, decrease in the stroke volume. The systemic perfusion goes down and there is compensatory vasoconstriction. And there may be a decreased coronary perfusion pressure resulting in ischemia, and ultimately there is progressive myocardial dysfunction and death, and end organ dysfunction and death. Now, we'll go a step further. Now, Kapoor et al. From the Tufts Medical Center, they say that cardiogenic shock is not only a hemodynamic problem, it is more of a hemometabolic problem, and the time frame right from the recovery to death depends upon whether it is a hemodynamic or it ceases to be only hemodynamic and becomes a hemometabolic problem. So initially what you see that anything which we do for the patient, for example a circulatory support, it is to improve the systemic perfusion, which is gauged by the mean arterial pressure and by the lactate and the creatinine levels. Plus, you need to provide ventricular support, either an LV support or an RV support. The LV end systolic pressure may go down, the LV end diastolic pressure may go up, and the aortic pulse pressure may become narrow, resulting in either ventricular tachycardia or an increased BNP. With an abnormal coronary perfusion, that is a mean arterial pressure minus the LV EDP, the narrower this difference, the poorer would be the coronary perfusion, and this would result in STT changes and troponin or CPKMB rise. And the final stage, it ceases to be only hemodynamic, it becomes hemometabolic, where you have abnormal renal parameters, you have abnormal mentation, you have abnormal hepatic parameters, and you require something to do a renal or hepatic unloading. So any mechanical circulatory support, inotrope, pressor should aim at restoring our normal circulation along with providing or unloading the ventricles and providing ventricular support and maintaining an adequate coronary perfusion, at the same time preventing renal dysfunction or hepatic dysfunction and providing renal and hepatic unloading. This is the stages of the SCAI stages of shock, right from the stage A, where the SBP and cardiac index remain normal, and then from going towards vasoconstriction, vasodilatation, where the systolic blood pressure may continue to fall, and the initial phases where you may have a stage of compensatory vasoconstriction, and then as you go towards a stage of C, D and E, you have compensatory vasodilatation, the SVR falls, the systolic blood pressure falls, and the patient develops end organ dysfunction. So once we recognize how do we diagnose and how do we go about classifying these patients, how do we risk stratify these patients of cardiogenic shock. So the most important thing in cardiogenic shock is that you need to put in an arterial line to monitor or look at the mean arterial pressure, and you need to put in a Swan-Ganz or a PA catheter. That is the essential of any hemodynamic monitoring in cardiogenic shock, because a PA catheter would help you in classifying cardiogenic shock and admission and would help you in risk stratifying these patients as and when required. So immediate assessment of hypoperfusion begins from as a clinical examination, as a fall in the systolic blood pressure. Continuous ECG monitoring is required. Echocardiography may need to be done to identify the etiology, whether there are any mechanical complications, to guide interventions and monitor response to therapies. A lung ultrasound or chest X-ray for the evaluation of congestion and pleural effusion may be required. And invasive monitoring using an arterial line is recommended in all cardiogenic shock patients. And obviously, as I said, right heart catheterization and pulmonary artery catheterization, they are required because these provide a robust assessment of the left and right heart systolic performance, and this can be used to make diagnostic and treatment decisions such as the initiation of and discontinuation of appropriate mechanical circulatory support based on the degree and type of ventricular dysfunction. So any initiation, escalation and de-escalation of cardiogenic shock, of a mechanical circulatory support in cardiogenic shock would be done on the basis of the pulmonary artery catheterization and the pressure monitoring, and these data can be used to calculate cardiac index, cardiac power output and pulmonary artery pulsatility index. So this cardiac power output, what is cardiac power output? So the various studies have shown that cardiac power output is the strongest correlator of mortality, and this has been shown across all the trials. So cardiac power output is measured as the mean arterial pressure multiplied by the cardiac output in liters divided by 451. So 451 is a constant, and any CPO value which is less than 0.6 watts. Now watts is the unit of cardiac power output. So any CPO which is less than 0.6 watts is associated with increased risk of mortality, and a CPO which is more than 1.1 watt, so you can go for, it indicates myocardial recovery, and you can go for de-escalation of the LVAD or mechanical circulatory support. The other terminology which commonly uses PAPI, which is pulmonary artery pulsatility index. So that is basically systolic blood pressure of the pulmonary artery, systolic pulmonary artery pressure minus diastolic pulmonary artery pressure divided by the central venous pressure. And if the PAPI is less than 2, usually you require some kind of RV support, like an RV impella, to support the right ventricle. So how do you risk stratify in cardiogenic shock? So the recent ACC-AHA guidelines, they have said that you need to have some kind of a hub and spoke model to risk stratify these patients in cardiogenic shock. So this patient, if you have any cardiogenic shock patient, so the first thing you need to do is to assess the shock severity, which stage the patient is in, whether the patient is having a worsening shock trajectory, what are the hemodynamics, what are the echocardiographic abnormalities, the vasopressor doses and toxicity, and the lactic acidosis toxicity or severity. Then you look at the phenotype. This is the phenotypical classification of cardiogenic shock. What is the cause, etiology, ischemic versus non-ischemic, whether it's a new onset versus acute and chronic, whether there is systolic dysfunction of the RV, LV, or it's a biventricular dysfunction, whether the patient is having only cardiac failure or cardiopulmonary failure, whether the patient is having a hemometabolic versus cardiorenal versus non-congested patient, and what is the congestional profile of the patient, whether it's an RV versus LV or biventricular congestion which the patient is having. Along with that, you need to look at other risk modifiers like whether the patient is having an history of out of hospital cardiac arrest, what is the neurological status of the patient, what is the non-modifiable risk factors, for example, age, organ function, the presence and reversibility of failure, and systemic inflammatory response. So this is the hub and spoke model of risk stratification of cardiogenic shock. Now these are the various risk scores. I will not go into the detail. These are the risk scores which can help you in identifying patients or predicting the in-hospital mortality or in-hospital risk of developing cardiogenic shock, and what is the mortality. So higher the score, higher would be the risk of developing cardiogenic shock, and higher the score, higher would be the mortality. This includes various variables like age, myocardial infarction, the heart rate, the glycemia, the the post PCI status, the post PCI TME flow. So all these parameters are used to calculate the risk of cardiogenic shock. This is another very commonly used risk score. It's a card shock risk score for the risk prediction of in-hospital mortality in cardiogenic shock. Again, you can see that it has parameters like age, presentation, confusion at presentation, previous MI or CABG, ACS etiology, EF less than 40%, blood lactate levels, and an eGFR or a declining eGFR. Again, an IIP shock 2 score. The higher the score, the worse is the mortality. Now coming to the mechanical circulatory support. Now there are a variety of mechanical circulatory support for the LV as well as the RV. For the purpose of this lecture, we will concentrate only on the LV support devices. So this is the 3 or 4 devices that we commonly have. We don't have all the devices with us. So the commonly used device is the IABP, the Impella, tandem heart and VA ECMO. Now you can see that as we go from the left to the right, you can see that all these mechanical circulatory support, the cardiac flow goes on increasing as we go from an IABP to an Impella to tandem heart and VA ECMO. So the weakest mechanical circulatory support is an IBP, but it's the cheapest. It provides a cardiac flow of around 0.3 to 0.5 liters per minute. Impella provides a cardiac flow of around 1 to 5 liters depending upon the Impella used. In Impella CP would provide around 2 to 2.5 liters per minute, and Impella 5 would provide a cardiac output of around 5 liters per minute. A tandem heart would provide a cardiac flow of around 2.5 to 5 liters, and a VA ECMO shows the maximum cardiac flow around 3 to 7 liters per minute. Now the mechanism IBP, as you all know, it's a very simple device. It's a double lumen catheter 7.5 to 8 French, which is inserted commonly through the femoral artery, and basically it inflates during diastole and it deflates during systole. It provides systolic unloading of the LV and also improves the coronary perfusion. The Impella is a device which is an axial pump which is placed like a pigtail in the LV, and from here it through a motor it throws blood from the LV to the aorta. The tandem heart is placed via a transseptal puncture and it pushes or throws blood from the LA to the aorta. And then you have a VA ECMO where you have 2 cannulas. The venous cannula, it collects the deoxygenated blood, okay, it sends it to an oxygenator, and from here the blood is oxygenated and it is sent back to the aorta via the femoral artery, and there is retrograde perfusion of the coronaries and the ascending aorta. The sheath size goes on increasing as we go from the left to the right. The cardiac synchrony is required for an IBP. It may not be required for all the other devices. Now, if you have a general look, the only important thing which I would like to highlight from this chart is that most of these devices, they improve the they improve the cardiac flow, they improve the cardiac power. But within VA ECMO and with the tandem heart, what you can see is that all of these increase the LV-EDP. Now, this is a very important concept which you need to understand, and nowadays any patient who is on a VA ECMO always has an LV vent. Now, the simplest explanation is that you are in VA ECMO, the blood is being returned against a closed aortic valve. So, what you do is that you actually increase the LV-EDP in the pulmonary capillary wedge pressure. So, you require something to actually maintain the cardiac output, and you require an LV vent, and this is provided by an IBP or an Impella. So, nowadays usually people don't put in just a VA ECMO. The idea is that you need to reduce the cardiac work, and then you need to create an LV vent and you need to put in an Impella. So the term which is now commonly used is an ECPella, that is the combination of VA ECMO along with an Impella. Now this is the pressure volume loop of a normal patient. Now as you see, if you go from the end diastolic pressure volume relationship, the vertical line is the isovolumic contraction, and then you have the stage of ejection phase, and then at the end of the ejection phase you have the end systolic pressure volume relationship, and then it comes down to the isovolumic relaxation phase. Now if you see on the left side you have PVA. Now this is the pressure volume area, or the pressure volume area, which is a combination of, or it's a addition of the potential energy plus the ejection work. So the total myocardial work is not only depending upon the cardiac cycle, it is also dependent upon the potential energy which is used to push this blood from the LV to the aorta. Now any circulatory support should also aim at bringing down the myocardial oxygen consumption. So this is the pressure volume loop in case of cardiogenic shock. You see that the end systolic loop is shifted downward and to the right, and you have this increased LV end diastolic pressures, decreased end systolic pressures, and a very narrow and short curve under the of the cardiac cycle curve or pressure volume curve. Now, if you look at the pressure volume curves of the 3 devices which we have discussed, so if this is an LV to aorta pump, which is an Impella, what you can see is that if you use an Impella, the pressure volume loop, it becomes more triangular, because now there is no phase of isovolumic contraction. And if you see, the Impella is actually the only device which is reducing cardiac work, because it is bringing down the area under the curve, the potential energy as well as the stroke work. The other devices, for example, an LA to aorta pump, that is tandem heart, and the ECMO, if you go on increasing the ECMO speeds, you can see that the cardiac the end systolic work it may improve, or the cardiac flow may improve, but at the same time you are increasing the LV EDP and the pulmonary capillary wedge pressure. So most of the patients, if they receive only VA ECMO, they tend to have a whiteout lung and they tend to have a closed aortic valve, which is not favorable. So after understanding these devices, okay, how do you select the patients? The ACC AHA says that you cannot have a single mechanical circulatory support for every patient. You need to select the right patient at the right time, at the right place, and the right treatment. So a patient selection is most important, whether the patient is having electrical or hemodynamic instability, whether there is ventricular dysfunction, which ventricular dysfunction, complex coronary anatomy, bridge to recovery or advanced therapy, goals of care and health values, the right time. What is the etiology of the cardiogenic shock? What is the SCAI staging, whether the patient is having the congestive profile, lactate clearance or multi-organ dysfunction. Then the right place and the right treatment. So you need to also understand that there may be a lot of local expertise in a particular mechanical circulatory support. For example, at our institute, we are mostly familiar with an IABP and we may not be familiar with Impella. So you need to select the mechanical circulatory support depending upon the institutional or the operator expertise and the best practices for vascular access, because most of these large devices require large bore familiarity with large bore access, because that can be a major source of complication. Now, this is the stepwise how you identify. So level 1 is cardiogenic diagnosis, cardiogenic shock diagnosis and stratification, no contraindication to escalation of care, adequate resources where the patient is can receive or escalate the MCA, staff, bed availability, hemodynamically stable for transfer. Then you classify the patient as whether the patient is having AMI cardiogenic shock or heart failure cardiogenic shock. So this distinction is most important because the AMI cardiogenic shock patients, they would benefit from revascularization also. And you may also select the mechanical circulatory support depending on whether it's an HF shock or it's an AMI shock. So if it's an AMI shock, you need to activate the cath lab immediately. You need to consider revascularization and early hemodynamics. And if it's a HF shock, worsening heart failure, then you need to initiate inotropes and vasodilators, and you need to look for a hemodynamic monitoring. So if you look for AMI cardiogenic shock and you feel that the patient is having a left ventricular profile with say a CPO which is very low but the PAPI remains okay, then you can consider an IABP or Impella CP. And if the patient has a really low cardiac index, cardiac output, you may consider Impella 5.5, although that would require a surgical cut down. And in very severe cases, you may need a VA ECMO plus minus an LV venting. If it's a biventricular condition or biventricular failure with a decreased CPO or increased PAPI, then you may need to go for a right ventricular support like a Protect Duo and Tandem Heart, or you need to go for bipella, that is you need to go for a VA ECMO along with a RV as well as an LV Impella, or you may consider a VA ECMO plus minus LV venting. And if you feel that it's a pure inferior wall MI and the CPO is relatively okay with a very low PAPI, then you may need to only put in an RV Impella or a Protect Duo, and in very severe cases again you may need to go for a VA ECMO plus minus LV venting. Now you may remember that IABP has not shown a mortality benefit in most of the ACS trials. The BCIS-1 was a trial in which it showed some benefit, but in the CRISP-AMI trial was shown that it did not reduce the size of the infarct in anterior myocardial infarction. And in cardiogenic shock, in the IBP shock trial, although there were a lot of fallacies, but it still failed to show mortality benefit at 45 days. So the recent consensus are that wherever possible, available, and Impella would be the mechanical circulatory support of choice. If not, in resource constrained settings, you may consider IABP. Now, if you come to heart failure shock and the patient is having a congestive profile, then if the patient is having say a left ventricular predominant shock, you may put in an IABP. Here an IABP would work in fact better than an AMI shock, but you can consider an IABP or an Impella, or you may consider a transapical or transseptal temporary LVAD. If it's biventricular, you may put in an Impella 5.5 to surgical cut down, or you may go for VA ECMO plus minus LV vent. Or if it's purely a right ventricular shock, for example, a patient with pulmonary embolism who is having RV shock, you may consider a Protect Duo or Impella RP, or in severe cases a VA ECMO plus minus LV venting. Now this is the SCAI, the Innova classification, which is most popularly used. Now you must understand that you have shock teams throughout the United States, as well as most. This concept is now percolating in India also, that you have shock teams, and each and every organization has its own protocol or algorithm which it tends to follow. Now the first step would always be that you consider or divide or differentiate whether it's an AMI shock or HF shock. So once you find out that the patient is having AMI shock, what do? So you basically you assess the shock severity, you assess the shock profile, whether the patient is having LV shock, RV shock or biventricular shock. You look for the revascularization, the mode and completeness, the presence of mechanical complications like VSD or MR, the presence of hypoxia, the presence of arrhythmias, contraindication to a percutaneous mechanical circulatory support, and the use of IV antiplatelet agents. So once you have found all these things, then you look at the SCAI stage. If the patient is say stage B, then the patient is not having any signs of hypoperfusion, so you don't require any drugs or devices. But if the patient is say proceeding towards stage C, you may consider either a trial of vasopressin or inotropes, or you may put in an IABP if the patient is having LV shock. Now if the patient is stage C, so you know that the patient is having hypoperfusion, the patient comes with a large anterior wall MI, you get an EBGA done, you find that the lactate is more than 5. So this means that the patient is having hypoperfusion, and so these patients should immediately be put on low dose or should be put on inotropes, and you would require some kind of mechanical circulatory support. Now if this patient is having hypotension along with hypoperfusion, and if the patient is having LV dominant shock, you need to go for IBP or Impella. Impella is preferable. If the patient is having RV dominant or biventricular shock, you need to go for Protect Duo along with an Impella CP. If the patient is say class SCAI stage D is deteriorating, then you may need to upscale. Suppose you have put in an IBP, you may need to upscale to an Impella. If you put in an Impella, you need to upscale to a VA ECMO or a LV vent. Especially if it's a biventricular dysfunction or RV dominant shock, the only thing you can do is to put in a VA ECMO plus LV vent. And if the patient is say stage E, then that is the stage where you need to consider strongly a VA ECMO plus minus an LV vent. Now on the left hand side you can see that it's a serial assessment. Now the main thing with cardiogenic shock management is that it's not static, it's dynamic. So a patient who is in stage C may not always be in stage C. If you assess the patient after 2 hours of revascularization, the patient may have moved towards stage B, or the patient may have gone towards stage D. Now if the patient is moving towards stage B, then you're happy. But if the patient is moving towards stage D or stage E, you need to be more aggressive. You cannot just wait and watch and pray to God that no, this patient will improve. So waiting is of no use, and you may need to be very aggressive in upscaling the mechanical circulatory support. The same is the case with HF cardiogenic shock. So the patient, you assess the patient for the same things which you have assessed. Now if you feel that the patient is in stage B, then you start him or a low dose of inotropes or vasopressin or vasodilators, and you may need to consider an IABP if the patient is having an LV dominant shock, especially if he is proceeding towards cardiogenic shocks stage C. If it is stage C, then HF shock, then you may need to consider IBP or Impella. Now in this case, an LV dominant shock, the IBP may actually work better than the rather than an AMI shock. But you can, if the patient is having very high lactate levels and is in hypotension, you may still consider Impella 5.5, where cost is not a problem. And if it's an RV dominant shock, then you may consider Protect Duo plus minus Impella 5.5. And if the patient is going towards stage D or stage D, you may consider either putting or upgrading it to an VA ECMO if it's an RV dominant shock. And if it's an LV dominant shock, you may consider putting in a transapical or transeptal temporary LVAD. Now if you look at the LV, how do you call it as LV dominant, RV dominant or biventricular? Look at the RA pressures, the pulmonary capillary wedge pressures, the CPO and the PAPI. So as I told you, these are the 4 or 5 parameters which need to be assessed every hourly in a patient with cardiogenic shock. So if the patient is having an LV dominant shock, the RA pressure is less than 15, the pulmonary capillary wedge pressure is more than 15, the CPO is less than 0.6 and the PAPI is more than 1. If the patient is having an RV dominant shock, the RA pressure will be more than 15, the pulmonary capillary wedge pressure would be less than 15, the CPO would be less than 0.6 and the PAPI would be less than 1. And if it's a biventricular shock, the RA pressure would be more than 15, the PCWP would be more than 15, CPO would be less than 0.6 and the PAPI would be less than 1. So this is the table in which you manage, or how do you escalate a patient, or up titrate the patient, or initiate mechanical circulatory support. So this is another guideline from the ACC AHA. So as I said, if it's at risk for cardiogenic shock, or there are high risk factors like, say, if the patient is having a large anterior wall myocardial infarction and the blood pressure is slightly on the lower side, you go for a radial access and you assess the LV-EDP and you do the PCI. And if you feel that the patient's LV-EDP is persistently high, then you may consider a PA catheter. And if you find that the PA catheter, you have signs of LV dominant or RV dominant shock, then you may need to consider a mechanical circulatory support after shifting to the ICU. Then the patient is in cardiogenic shock, the same as we discussed. You do a PCI, and during the PCI, pre-PCI, you assess the LV-EDP, you look for the RA pressures, you look at the CPO, and you look at the PAPI, and then depending upon that, before starting revascularization, you need to put in the mechanical circulatory support, and that would help us in the ease of the PCI. At the same time, it would also help us in completing the procedure and post-procedure early weaning. Then if you look at, if it's a cardiac arrest patient, upfront strongly recommended mechanical circulatory support, and you may also need to consider the strongest support available to us, which is a VA ECMO with an LV vent, because these are the patients who are the sickest category of patients and would require the strongest mechanical circulatory support available to you. And this is the management of heart failure shock. So you have signs and symptoms of heart failure cardiogenic shock. Check blood pressure and consider PA catheter placement, assessing the severity and profile. Then if the patient is adequately congested, then initiate diuretics. And then if the mean arterial pressure is less than 65, you consider inotropes and vasopressors plus minus IABP. If the symptoms improve, then you continue the same and then wean. Now I will come to the weaning protocol in the next slide, but if you find that the symptoms have worsened, then you need to reassess the shock severity, and then you need to consult the shock team. And if there is symptoms of LV dominant shock, then you need to initiate an Impella CP or 5O or a tandem heart, or you need to initiate an LVAD. And if you feel it's a right ventricular shock, you may put in an Impella RP, a tandem heart, or VA ECMO. And if it's a biventricular shock, a VA ECMO with a LV vent, like or a bilateral or a bi-impella, that is bipella, or RV impella with an LV impella can be considered. Now this is my last slide, and this is the weaning protocol. Now again, almost all the organizations have their own weaning protocols. It is not universal. So if the patient is, say, treated, improved, or resolving, the underlying condition is resolved, and the end organ dysfunction is improving or restored, then you may depending upon the hemodynamics, you may down titrate the mechanical circulatory support. If the patient is stable on inotropes and low dose vasopressors, the mean arterial pressure is less than 65, the pulmonary arterial pressure, the RA pressure is less than 10, the pulmonary capillary wedge pressure is less than 15, and you have a PAPI which is more than 1.85, and the CPO is more than 1.1. And if physical examination and on echocardiography, if you feel there's a significant improvement in the ejection fraction, the lactate levels have come down, your urine output is adequate, the LFTs have improved, then you go for a device specific weaning protocols. Now I'm not going to the detail of every device, how you wean off, that would be an entire lecture altogether. But once you wean off, you have to repeatedly comprehensively assess the patient, because sometimes what will happen is that the patient may actually deteriorate after weaning or rapid weaning. So you have to be very, very careful. This hemodynamic monitoring has to be regular till you feel that the patient is now completely weaned off and the MCS can be removed. And sometimes if the weaning attempts have failed, then with multiple MCS, then either you may need to continue the support, or you may need to consider bridge to transplantation. You need to put in a temporary LVAD and consider the patient for transplantation. And if the patient is totally off inotropes and is requiring no inotropic support, no vasopressors, and is more than 48 hours, he's okay, doing well, then you may need to decannulate the MCS. Thank you.